Go.
Hi, we're Maddie, Becca, and Summer, and this is our final oral report. Before we get into how we're going to tackle this huge problem of postpartum depression, we just wanted to give a quick overview of our preliminary report and an overview on depression in general. Postpartum depression is the most common complication related to childbirth. While postpartum depression is treatable, many women who suffer from it remain undiagnosed. Untreated postpartum depression can last as long as 1 to 2 years and may affect the ability of a woman to function in normal daily tasks. Further, untreated postpartum depression may impact family relationships, a woman's ability to bond with her baby, and the cognitive development of her baby, as well as other children in the home. There may be a variety of reasons why a woman does not receive treatment for postpartum depression, including the inability to recognize the signs and symptoms, as well as uncertainty of knowing who to ask for help. So we know that surveillance of a disease or condition is really important in the healthcare field, and it's how people make decisions based on evidence. So according to the National Pregnancy Risk Assessment Monitoring System, exactly 15.3% of women in Utah reported frequent postpartum symptoms, which is the second highest of any of the states. 26 states actually reported in 2009 and 2011. So every day different decisions are made about how to intervene with a disease outbreak, or even which disease or condition to worry about. And public health officials make those decisions based on the data given to them by surveillance programs like the Pregnancy Risk Assessment Monitoring System. Some of the factors that lead to postpartum depression are here in white, and there's a lot of them. So much that we'll kind of cover these later on as we move on and talk more about specifically Utah and some of the bigger factors that play into postpartum depression in Utah. And as we go out throughout this program, when we say we're referring to this organization that we've created for this project, a physical organization called Project Blue. And we'll get a little bit more into this later on as we go.
Okay, so we know that postpartum depression does not only happen in one specific country or one specific place. It affects many women in many different places. So we decided to look at different successes that other countries have had in with postnatal care and with postpartum depression. And one place that we found that did something a little different is Holland. And Holland, they use a system called the Kramzorg system, where Dutch women are receivers of a postnatal caregiver who comes in their house and lives with them for 8 to 10 days after they have their baby. It's kind of cool because some of the things that this caregiver does is they teach the mom how to breastfeed her baby. If something goes wrong, they can help. The mom can get the rest necessary to function. And she also, the caregiver will also make her meals and take care of her family members, her children, and those who come and visit her house. They'll clean their house. And they do a lot of different things. And so we're going to talk a little bit later about how we want to implement this same system here in the U.S. and in Utah, and how it would be beneficial for the emotional, physical, and stressful, and take off these burdens off of new mothers who are going through a lot.
Okay, so going back to Utah, we just wanted to review some of those issues that are specific to Utah. So some of these issues include a stigma against sharing mental health problems or fear of appearing imperfect. And then so there's often a lack of support or communication because of that fear. In Utah, there are a lot of stressors during pregnancy and during life in general. We know that that's one of the areas where things move pretty quickly, and that's part of the feeling that you have to be perfect, is you always have to be doing something. It's also one of the areas that frequently tops the list for mental health issues. Depression and suicide are a huge issue there, and those are big factors in postpartum depression. Then, of course, other general factors like social class or income that you see anywhere. So Considering both those global solutions we looked at and the Utah-specific problems, we came up with an intervention that we feel like is both reasonable and effective for combating postpartum depression.
So we have 3 stages in this program. Stage 1 is the prenatal education and screening, where will be offered in hospitals by doctors and midwives, things like that. In stage 2, this is where we have the neonatal support, which moms can get right there in the hospital right away after having the baby. And then in stage 3, we will have postpartum check-ins and a follow-up with a new mother.
Okay, so let's start with stage 1. These are all the things that happen before the baby comes. We have 3 specific bullet points that we want to focus on. The first one is hospital education, and then hospital screening, and then preparation to support mothers that are most at risk. So hospital education basically means that we're going to educate the soon-to-be mom on what to expect and how to look for the signs of postpartum depression. We're going to possibly offer community classes so that they can be involved and be prepared. And also, we're going to send out letters to have these women come in for screenings and provide pamphlets and more educational resources for them. And then the next is hospital screening. We want to make an in-depth questionnaire about previous health issues, social class, family history, support systems, feelings about pregnancy, etc. Basically to see who's at risk and who's more at risk for postpartum depression. And all of these factors, like we learned earlier, affect postpartum depression and play a role in that. And so here's an example of different screening questions. These are obviously not all of them that we would have ideally, but just some examples are their education levels, and do they drink, do they smoke, what are their relationships like, what are their views on pregnancy, have they been pregnant, and how'd it go. And just knowing these basic things would help us understand kind of where they're at and if they are likely to have postpartum depression like in the future. And then we know that questionnaires must be optional, and we would do our best as an organization to encourage this, as we want to help and offer services to those who need it most. And we administer this screening at pregnancy appointments, and we'd mail it to women who perhaps didn't take it, and make it more available to those and promote it and make sure that we can get as far reach as possible. And participants who show multiple risk factors will be given top priority for intense care in stage 2. So that brings us to stage 2.
So stage 2 is after you've had the baby. Woohoo, congratulations. And now we're focusing on providing as much care as physically possible for as many people as possible. This stage focuses on recognizing early when people are starting to develop postpartum depression, and also possibly preventing that by setting them up for success and providing support during the most difficult period while you're learning how to take care of a child, during those first 2 weeks. So this is where we'll talk about how we would incorporate that Holland model. So we've all seen a woman who's in her first few weeks of motherhood. She usually has circles under her eyes, slightly disheveled hair, and spit up in at least 3 different places on her outfit. But in many cases, she's also smiling because, despite the difficulties of learning to raise a child, this should be one of the best experiences in your life too, holding your child. But unfortunately, if there's any time that your mother is likely to feel like overwhelmed, and so overwhelmed that she can't enjoy this experience, it's probably that first few weeks of motherhood. So that's why we believe it's so important to have as much support as possible during those early days, so the new moms can start things off as smoothly as possible. We hope that by providing that support, we can prevent many of those feelings that will lead to postpartum depression. So to do this, we want to tie in what we learned from Holland. We want to have as many nurses or trained personnel in new mothers' homes, as many as possible, to ensure that every mom has the best chance of success she can have. As for how we actually want to implement this, we thought we could follow in the footsteps of a system that already provides like state-funded in-home care for people who need it. Those programs are called residential habilitation. They're for adults with disabilities. Basically, res hab programs, they're like businesses that employ and train normal people to work under licensed medical professionals so that disabled adults can have support they need to live as independently as possible. So the next slide has a diagram of sort of how this works. You have physicians who are obviously the first line of care. They give prescriptions and things. Then nurses who oversee a lot of these. UAP stands for unlicensed assistive personnel. It just means like a paraprofessional who doesn't have any medical licensure, but is trained to help with specific tasks. So these are the people that we would have in the homes. They would be trained to recognize the early symptoms of postpartum depression and be able to report those back to nurses. It may not be exactly like home, or maybe wouldn't have them in the house 24/7, but they would definitely come to visit and help the mother deal with these things. It's a cool system because it sort of distills the information. Like obviously we don't have enough doctors and nurses in the world to stay in every new mother's home. But so we have paraprofessionals, they can be trained to recognize specific issues and then report those back to the people. So you get the information to the right people when you need it and reach as many people as physically possible.
So this brings us to stage 3 of our intervention. And this really focuses on 2 weeks after the baby's born and all the time after that. And so the main goal of stage 3 is to make sure that mothers have been set up with resources to reach out if they feel postpartum depression coming on, maybe if they didn't recognize it right away. And obviously we realize that we can't have intense support for all mothers going through their first year, but we can take preventative steps with as many people that are at risk as possible. And we can try to establish this by having online communities, so to say, where people can feel safe to ask questions, to come and bounce ideas off of. On this next slide here, we have a picture of an Instagram account that we set up for Project Blue in Utah. And so like this is an example of a post that we might make. And we would want to include hashtags, things that could bring in as many people as possible so that women who are feeling blue, even after this 2-week period of checking in with doctors has passed, they can still get the help that they need. They can still ask their questions, find solace in having friends that are going through the same thing, and maybe even talk to professionals while they're there.
Okay, so some barriers that we found with the system from Holland could include having strangers in your home. Perhaps that would be something that for a new mother, maybe she would feel uncomfortable to have somebody new in her home who she perhaps doesn't know. And especially since this is such a vulnerable time of her life, she probably would feel uncomfortable. So that's a potential barrier. Another possible barrier or difficulty could be personality differences, different expectations, perhaps cultural differences, because we personally have not seen a group like this, like our organization. We haven't seen something like this. So perhaps there's cultural differences in other places where they're more accustomed to this idea. And then funding for in-home nurses or paraprofessionals. And then we were also thinking legal issues. There could be liabilities involved, although that would be something to be resolved, and we are confident that could be done.
With the financial thing, especially for the stage 2 in-home people, we had looked into having state-funded things, and we know that that's possible because we've seen it with the residential rehabilitation programs. I mean, there have to be specific conditions that you meet. There have to be like legitimate medical reasons to have somebody there. There have to be conditions before someone can get into the program, which is why we'd have those screenings and say, you know, this initial thing is primarily people who are high risk or who show immediate signs of postpartum depression. So those are some sort of things that we would do to overcome those. And another thing, obviously, when we're dealing with volunteer information, takes people stepping up and telling us about certain things before we can really do anything, which is why we want to focus so much on the education at the beginning and social media places where people can get information, feel normalized about mental health issues, and just be as open as possible so we can be as effective as possible in dealing with this. We really think that this would be something that we could do. We've seen lots of similar programs or things that are along the same lines that have worked, and so we feel confident that we could overcome these barriers and make it work.
Perfect. And that's our presentation.
There's an end, isn't it?
Okay, let me stop it.